Yeah.
So, should I introduce myself right now?
One second. Yeah, 1 second. Because now we're looking. We are live. Welcome to International Days. Today we are now, at this moment, this time of the day, we're having a conversation which we connect the Netherlands with Turkey to Istanbul. And we welcome Associate Professor and Senior Lecturer Ayca Aklar Corekci. I hope I pronounced your name correct. Which is a very respected colleague of mine and a very inspiring person concerning physiotherapy, musculoskeletal care, and women's health. And she will bring us on women's health. Ayca.
Thank you very much, Joost, for your invitation. And it is very great pleasure to be in here with you to discuss the topic of pelvic health. And it's a very narrow issue, but it is very important to know for all the physiotherapists because it's so common that I will explain in my lecture or speech. I don't know how to name it. Thanks a lot, and being with you again, even though online is very great. So I want to introduce myself at first. I'm graduated from physiotherapy physiotherapy college at 2003, I guess. it's been hard. So, and after that, I had my master's degree on biomedical engineering, and I'm newly graduated from PhD in 2020 from biotechnology. My expertise is on musculoskeletal rehabilitation, and I'm also an osteopath. And 2 days ago, I get my osteopathy instructor certificate also from Osteopathy Schule from Berlin. So my practice is basically on person-centered rehabilitation, but my emphasis on pelvic pain, persistent pain, and incontinence. Since 2010, I'm working on this subject. So today I will share with you my experiences and some topics about pelvic health. And also you may all the time interrupt me, stop me and ask questions. I will be glad to hear your questions and feedbacks. So I had an introduction slide, but I will pass it. So pelvic health on women's and men's is very common among patients. Most of the time, and I was an emphasis on this subject and working on it especially, I can figure out that women with low back pain, men with low back pain may have some problems related with the pelvis or pelvic floor dysfunctions. I'm not sure you are seeing patients right now, but when you get the history from a woman, you may hear that she has a leakage. And having a leakage is a very important thing for life quality because it stops everything, the social activities, the working life, even it affects the posture of the woman. So when you just pass through it, just deal with the pain of the patient, you may have some problems to heal the whole person and whole problems. So I want to emphasize that one of three women has leakage, and only 25% of them seek for the help for this problem. So for a physiotherapist, it is a very great way to understand their problems by history taking process. So The low back pain and pelvic pain is considered as siblings together. So one has low back pain, expect to have pelvic pain also, or vice versa. So if a person comes to you, consults to you with low back pain problems, you may also ask about their pelvic problems. So asking about pelvic problems is very important. If you say someone, do you have any problem with your urination, or if they have a problem with their bowel system, so you may have misunderstanding, and you can have the correct results from the patient. So I want to mention about some assessment and history taking, and how can you ask the patient about this specific problem. There are some common urogynecological problems that you may encounter with the patients. One of them is incontinence, prolapsus, pelvic pain, sexual dysfunctions, vulvar pain, and cystitis are the common problems, urogynecological problems. So body charts, history taking, and some digital palpation tests you can use easily. If you are not a pelvic floor therapist, you don't need to have a lot of device at your office. You may have some knowledge and some, you have the palpation techniques, and you may just check for the contraction. And with the expertise, you may get some increased sensation, and may have some ideas about the muscle function. For the pelvic pain, we have some body charts. Especially, I use these body charts to understand the source of the problem, because low back pain may, they can represent this on the body chart by a different way. And if there's a pelvic pain, its representation is different. If there's a pelvic pain, vulvar pain, it is more about the vulva, the gluteal region, inguinal region, and especially the adductor regions. Sometimes, because of the connection of the obturator nerve, they may have some knee pain at the medial part. Also, they may have sexual dysfunctions. I know that it is very difficult to ask a person about their sexual life. Have you ever considered asking a patient about sexual activities, or how is everything going? Will you be comfortable about it? Did you ever think about it? Is there anyone want to contribute about this?
No, I never did that.
Yes, it is very difficult, and first of all, you need to be comfortable while asking, because you're asking very private questions about their leakage, about their sexual activities, about their pain during sex. So it is very hard to make a dialogue about these questions. But when you have the confidence and you ask the right question, patients feel like the first time someone will ask this question to them. It is very important for them also. So you have the connection, you have the dialogue, you have the attention of the patient right now, because you're asking some question that no one asked before. So when we are talking about these pelvic problems, so you don't have to ask everyone about their pelvic problems, but there are some scales also asking about, like Incontinence Society scales, asking about their urogynecological problems. You may use the scales, there are the right questions in there. Or you may choose some questions from there. For example, when we talk about the incontinence, and when you learn that woman has a pregnancy, has child, you may ask, first of all, you may just start with asking about the birth condition, birth injuries, the kilogram of the baby, the length of the birth, and if it is difficult, if they use any devices like forceps, you know, they just use it to take the child off. So you may ask about the birth conditions. And if you hear something about a difficult birth or episiotomy, you know that episiotomy is commonly used in a vaginal birth to increase the opening of the vagina and letting the baby more easily outside from the vaginal canal. So when there's an episiotomy, it may cause birth injuries to the pelvic floor. So if you have this clue that this birth and child number and pregnancy number may have an effect on pelvic floor, so you may ask about the leakage. So there are different ways of the leakage. So when there's an incontinence, there may be a stress urinary incontinence. When I say stress, there's not something about psychology. This is the stress acting over the pelvic floor muscles. Can you consider any condition may cause a stress over pelvic floor muscles?
Sorry, could you repeat the question, Ayca?
Can you imagine any condition, any movement, any activity may cause stress over pelvic floor muscles? So we call it stress urinary incontinence.
Oh, when you're bursting out of laughing or sneezing or something like that?
Yeah, yes, laughing, sneezing, carrying a heavy object may cause a leakage. So it is called stress urinary incontinence. And another type of incontinence is the urge incontinence. Have you ever heard about it? Urge incontinence? So urge incontinence is something that without the filling of the bladder, you know, when you feel that you need to urine, it is the 30 or 40% bladder capacity is full and the muscles around the bladder activated. And this activation causes some feeling about going to toilet or emptying the bladder. When you, in this kind of patients, there is an activated detrusor muscle. The muscle around the bladder is called detrusor muscle. It is an activated detrusor muscle. So without getting out the filling capacity of the bladder, patients feel like they are going to have leakage and they feel like urge to go to the toilet, and they feel like they will leakage and feel like urge to go to the toilet. But even the capacity is not totally full, or it is just feel about 30%. So it is a result of the hyperactivity of those bladder muscles. And we can see it together, both the stress urinary incontinence and urge incontinence. The stress urinary incontinence has some risk factors, and we will discuss it. Urge urinary incontinence, much more about neurological conditions. It is like autonomic imbalance. And different types of continence, and knowing their difference changes our rehabilitation techniques with the patients. And it also, you may have it from the history. So if someone is telling you that I have a leakage during coughing or sneezing, So you may think about that there's a problem with the supportive tissues. So I will give detailed explanation about the anatomy, but I always like to give the total knowledge and then get to details as much as you want. So when you talk about the anatomy of the pelvic floor, there's a dynamic, so contractible part of it, the muscular part, and the passive non-contractible part. So these passive forces, passive structures provides the support to the muscles, attachment around the pelvis, and those muscles, the elastic ones, provides the contractibility. So you know that from the muscle physiology, I guess all of us know that the relation between sarcomere, the actins and myosins, and their optimum contact is very important for the muscular strength. So think about the muscles just packaged by some fascial structures, and it is like a cake. One layer is muscle, one layer is fascia, one layer is muscle, and one layer is fascia. And also all of these muscles are skeletal muscles and full of fascia inside it. So, and they are attached to the pelvis at the lateral part, at the posterior part and anterior part. And there are organs just coming up the pelvic floor. So it needs a support, and it's a supporter for the pelvic organs. And also it controls the leakage. So when they contract, they just make a pressure over the urethra, just behind the pubis. And by this pressure, they just increases the urethra pressure and prevents the leakage. And when they release, you will be able to empty your bladder or empty your bowel. So when you lose the support, you may lose this muscle support, muscular contraction, and you may lose the fascial support. So as we talk about the pregnancy, as we talk about the episiotomy, so the pregnancy, the load of the baby, and it is for 9 months, may cause a disturb of these fascial structures, and also lengthening of these fascial structures may affect the muscular contractions. So both of this effect of the pregnancy, at least around the 6 months of the pregnancy, most of the women have incontinence problem, basically the stress urinary incontinence. When there is a problem with this supportive tissues, consider that there's a pipe just giving water, like a garden watering, you know. When you just put your foot over this pipe, so if the supportive baseline is strong, when you put your foot, so you can just stop the water leakage. But if the supportive structure is smooth, like the sail, when you just put your foot on it, so your foot will get into, the pipe will get into the sail, so you cannot stop the water leakage, it will continue. So this supportive structure is the pelvic floor muscles, and their strength is very important. Both the fascial and the muscular strength is very important. So do you think when we need this support, and when you should increase your pressure over the urethra? Do you have any idea? When you should need?
Anyone?
I'm just asking. I know that it's a very different subject, and I just wonder if you have some opinions about it. So don't feel any pressure. I know that it's a lot different.
Can you just repeat the question because I got a noise in between?
Okay, I was just telling that the pressure over the urethra is provided by pelvic floor muscles. And I just want you to think about a condition that you want to increase this pressure and provide a muscular activity over the urethra and close it and to stop the leakage.
So in what situation do you want the pelvic muscles to contract, you mean?
Yes. I'm asking about a situation that you may need an extra activation.
When you're doing physical activity, I think?
Yes, doing physical activity.
Yeah, jumping.
Yes, jumping, sure. We can make it a large perspective that when you increase your intra-abdominal pressure, so when you increase your intra-abdominal pressure, the pelvic floor muscles eccentrically activated and closes the urethra and prevents the leakage. So when you lose this supportive structures, both the fascia, both the muscle activity, you wouldn't be able to quickly contract this muscle group and may have a leakage. So urge incontinence, as I mentioned, that feeling of urination and an urge to empty the bladder is not related with the supportive structures and pelvic floor muscle weaknesses. Stress urinary incontinence, if you have in the history taking process, if someone tells you that I have a leakage with sneezing, coughing, physical activity, so the activity is increasing the intra-abdominal pressure. So you may think that this is something about the supportive tissues, and physios are very effective to fix this problem. If it is not related or if it is not, you know, if you lose all the elastic properties of the fascia. So if you just increase the plasticity, you know the plasticity, I guess you know it. The point that you just overload and lose the stability. So this is the plasticity of a material. And when you increase this level, you know that there's no turning back. You consider that you have a sister, an older sister, and you have a very stretch shirt full of elastin. And one night you figure out that your older sister wear that t-shirt, and the other day you want to wear it and it is not just stretching over you anymore. It is elasticity is gone because your sister was older than you. So this when you lose the elasticity, there's no turning back, and so there may be some fascial operations to the patient. So it is beyond our activity, but still we have some things to do to prepare the structure to the surgery, to prepare the muscles to the surgery, to teach the muscular activity. We will talk about it. Urge incontinence is different. Urge incontinence may be a result of hypertonicity of the pelvic floor muscles. As I told you that supportive structures may be weak and there may be leakage. So consider that these structures, just above them there is the bladder, and the bladder is covered with muscles, and all these functions are controlled by autonomic activities. When I say autonomic activity, I say the parasympathetic and sympathetic balance. So parasympathetic system is activated, the detrusor activity increases, the bladder muscle activity increases, and you feel like you need to go to the toilet. When the sympathetic activity is increased, so the sphincters are closed, so you can hold it further. So there's a balance in this system. When we talk about the urge incontinence, we lose this balance sometimes. The detrusor is activated earlier than it should be. And this could be a neurological problem. There may be some diseases like multiple sclerosis under it, or some problems, neurological problems, or some medications that we use. And also the hypertonicity of the pelvic floor muscles may irritate those structures. And also some other organs may affect by visceral relations, like irritable bowel syndrome, like endometriosis. Irritable bowel syndrome is a problem. Patient has some gases problems, and pain in the intestinal system. Sometimes it shows with diarrhea, and sometimes it shows with constipation, but basically they have some sensitivity over the bowel. And also endometriosis is a condition, a gynecological condition, just the endometrioma, the inside the uterus, may just grow outside the uterus, especially during the menstrual process. And it is very common among women before menopause. It is shown with increased menstrual pain. So you may get this from the history of the patient also. So some problems may just interfere each other, and we call it just comorbid conditions, may affect each other. And urge incontinence sometimes can be shown with pain. So we call it bladder pain syndrome. Sometimes it could be just the incontinence, the urge incontinence, feeling like urination. So prolapsus, when there's a prolapsus, as you see in this slide, in here, the vagina, and it is fascial support is very important for the contraction of the pelvic floor. It is considered to be to just transmit the loads from the posterior part and anterior part. The vagina wall is at the medial part and transmits the force and provides a better contraction, proper contraction, and provides the urine leakage. In some conditions, especially being a female is a risk factor, so don't be a female. It's a very when we explain something like that, so we just figured out that some anatomical differences between female and male may cause this problem, because we have this opening to outside, and this opening makes us vulnerable to this urogynecological problems. So being aware of that, maybe you may have some pregnant relatives or patients. You may see some patients with low back pain syndrome. So this is why you should know that there's a condition that females are vulnerable to. So you may ask about this in their history, and you may give some really easy exercises to them and may prevent the problems. So prolapsus is one of them. The anterior vaginal wall can be defected, or posterior vaginal wall can be defected. Those have some different names that I don't want to confuse you right now, but you may have some research if you want to read further, like prolapsus. Pelvic pain is very common, especially during pregnancy. It is common than you think. But as I told you, the help, they don't seek for help most of the time because they consider it normal, because their neighbors has a leakage too, or their sisters had pelvic pain during their pregnancy too, or physios don't want to you know, while you're during pregnancy, you need to have some knowledge, and most of the physios don't want to make a treatment over a pregnant woman, so they may consider it as normal. So most of the pregnant women seek for help, but sometimes they cannot find a solution. Pelvic pain is very common. Sexual dysfunctions are very common among male and female. So there may be some different reasons for that. For example, when you consider the male, their habits, their adherence to the activities, their hormonal function, there are lots of risk factors and lots of reasons for that. So it needs a detailed history taking. And there may be some pain around the vulva, and this vulvar pain may be a result of neuralgia of pudentus. Nervus pudentus innervates the vulva. It has 3 branches. One is to the clitoris, one is to the perineum, one is to the anal sphincter. So these 3 branches, you can evaluate in between with the digital palpation. You may consider, we may talk about it later. And due to this prolapsus, due to this urge incontinence and other problems, there may be a problem with emptying the bladder. And when you cannot empty your bladder properly, it may cause a cystitis of the bladder. You know, there's a bladder infection all the time. So when a patient consults you with low back pain, sacroiliac pain, you may ask about their bladder infection, if they had it frequently or not. You may ask about their pain during sex. Basically, you may ask them about their, if they are female, about their dysmenorrhea, if they are having pain during menstruation. And you may ask about their leakage, if they have a leakage, or if they have an emptying problem and you just sit down on a toilet, if you have a hesitation while urination, you feel like you cannot do it. So if some of this problem is present, so you may consider about pelvic floor muscles. So it was a lot of knowledge as far. Do you have any questions about this? Or maybe you may think about a patient you see we can discuss.
I have a question for you, Ayca. I'm actually very curious about how this is a topic that is not talked about often, especially in the course of physiotherapy. And I was just wondering, imagine if I have a patient that has pointers that lead towards pelvic pain or any leakages, how would you start that conversation? Because I can imagine it's very difficult for patients to, especially if I'm a male therapist and it's a female patient, how would you start that conversation? I'm just curious.
Basically, I use some scales. You know, I work in pelvic pain, and I can write you on the chat. There's the I'm also a member of International Pelvic Pain Society, and on this International Pelvic Pain Society webpage, you may find evaluation forms. If you want to, you can download it from there. So As I'm a researcher, I need to take some documentation, and there are some scales in it. As I'm an osteopath, I always ask about the visceral system. So basically, I don't ask about, for example, do you have a cardiac problem, for example, because one cannot know if they have a cardiac problem, but I may ask them, maybe it is much more familiar to you, so I'm giving this example. I may ask them about their exercise status. So I may ask them if they can climb stairs. So when they tell me that, no, I cannot climb any stairs, so I can ask why. I may ask them if they are sexually active. I may ask them if they say no, so I can ask why. Or I may ask them if I just specifically can ask because I'm working on this condition, and it really provides a relief on the patient. But if I was working with just musculoskeletal care patients, so maybe I can ask them if they, for example, a low back pain patient, I may ask them about their pregnancy, the sexual, if they are sexually active. I may ask their pregnancy, if they had any child. So I know, because I know that it's an risk factor and increases the probability of the pelvic floor dysfunction. Or I may apply some, there's not evidence-based test, but if you apply some 4 or 5 of them, and if I find some pelvic pain, and this provocation test positive, so and then I may ask them, as I just find this test positive, I want to ask some further questions about pelvic floor activities. So these are related with urination and sexual activities. Then I can ask them about their, how many times do they go to the toilet? Because constipation is another risk factor for pelvic floor dysfunction, because they will just, the patients with constipation, or the people with constipation, when they try to empty their bowel, they just strain the pelvic floor muscles. So I may ask about this, how many times do they go to toilet? And then when they tell me that it is not often, or 2 times a day, so I can ask that if there is a constipation. So when they tell me that if there's constipation, so it is the second risk factor. So I may ask about if they have an hesitation while doing urination, if they have leakage during coughing or sneezing, or if they have physical activity and physical activity related leakage, then I may specify. And when the questions are have some positive results, so I can ask about sexual function questions, if they have pain during sexual activity. Basically, if there's a pain, if it is just beginning of the penetration or end of the penetration. So if it's at the beginning of the penetration, it may be a result of vulvar pain, pudendal neuralgia. If the pain is just in deeper stages, so it may be related with the endometriosis. And the patient, when I look through the history back, patient has an dysmenorrhea. So the two match is gives me a lot of about the patient's condition, I guess. Does it make sense, or just
yeah, it makes a lot of sense.
Also?
It is a complicated issue, but I think I got the grasp of what you were saying. It's just you have all these, let's call them red flags, that you ask the patient, and if you see some of those red flags, you can identify whether it's has to do with the pelvic dysregulation or not.
Yeah.
Okay, thank you.
You're welcome. And as I told you, as we have the opening to outside, and these fascial structures may be affected with the pregnancy and the birth. So females are much more prone to have urinary problems. The menopause may cause this leakage, birth injuries, hypermobility, and impact of exercises. The impact of exercise, you're a CrossFit, how can I say, you do support as a CrossFit. So you need to have heavy lifts. So you need to prepare your pelvic floor muscles also, because most of the CrossFit women may have leakage. But they don't tell you. So while giving CrossFit exercises, so you must prepare the pelvic floor muscles. Also, we will explain it with some exercises. And as I told you, constipation is a risk factor because you strain while defecation. Obesity is a risk factor because it causes a lot of pressure over the pelvic floor muscles, and pregnancy also. So sometimes I hear that don't lift heavy things. So when we see the risk factors, I feel like I'm about to say that don't be pregnant, don't be female, or don't do CrossFit, don't lift heavy things. So these are very exhausting and very risky words to explain a patient. So we don't explain, basically I don't explain patient that you have the pregnancy, so your pelvic floor muscles are weak, or you are a CrossFit sporter. I don't know, how can I tell a person doing CrossFit? So you are prone to have leakage. So it is very important to choose the right words to the patient. So there are some facts, but these facts can be modified, and pelvic floor exercises, pelvic floor physiotherapy is very effective to do this. For example, if you're a female, you may be aware that your pregnancy, birth, or if you don't have any birth, even though you may have urinary leakage. So you need to be aware of your pelvic floor muscles. So before the birth and after your pregnancy, after giving the birth, you may see a specialist, or you may just give some knowledge to your patients about their pelvic floor muscles, because you know that it's a risk factor. So you should be careful about these problems and give some exercises to strengthen them also. So if I want you to squeeze your pelvic floor muscles, what do you imagine? Especially you, Max, do you have any idea where these muscles and how to contract?
I think it's just bracing, like that's what I associate with yeah. So bracing your stomach, and yeah, I think that's it.
So it is very common for us to use our arms, or to bend, or to do some activities with our extremities, but when I ask someone to squeeze the pelvic floor muscles, it doesn't have any imagine like that, because they don't know where the pelvic floor muscle and how to squeeze. And most of the time coming from the childhood experiences. For example, how many of you just hold your pee and continue to play during your childhood? I did, okay. So from the childhood experiences, you have this conservative and you have this hypertonicity at your pelvic floor muscles. And you know, this is also a motor learning process for you. You learn to do this. So when I say just relax your pelvic floor muscles, how do you feel about it? Can you figure out how to relax it?
Quite difficult, actually. Well, it sounds like from you start trying to contract, and then it's mostly stop contracting. That's the closest I think that I can get, but don't know.
I feel the same way.
Most of the time, that contraction or releasing doesn't have any idea, especially for the patient. So you are the physios, you know the muscles a lot. Even though you have some problems imagining the pelvic floor and contracting and relaxing, and consider the patient that they never use this group of muscles voluntarily. You know, we use it involuntarily. So when I ask a patient to voluntarily activate the pelvic floor muscles, they increase the abdominal activity, or just they squeeze the gluteal muscles, or they just close their lower extremities and activate the adductor group muscles, or they just try to strain and not contracting, just straining. So most of the patient doesn't know correctly contract the pelvic floor muscle. Even if a physiotherapist detailer explained how to contract the pelvic floor muscles. So we use digital palpation techniques for it. And there are lots of ultrasonography, biofeedback devices, perineometers to assess objectively. But basically in the clinic, we use our digits. So intravaginally or intraanal, we place our digits and ask the patient to squeeze. But there are two function of the pelvic floor muscles: squeeze and lift. Okay, you may feel this lifting with your finger not correctly, but you can feel the squeezing. So you may just by this way evaluate the function of the pelvic floor muscles. This is just the function, and you may evaluate the strength. How many force acting over your digits, and if they can lift or not, if they can squeeze properly. You can just check for the strength, and also you can check for the endurance. So they can squeeze and hold it in there. Okay, how many minutes they can hold this muscle, and how many times they can do it without a fatigue. So this is a principal muscle testing technique, but consider that these muscles does not cross a joint. So they don't cross a joint. So for that reason, you cannot see any motion. So you can just have the pressure they are doing. Okay, so we use some pressure measuring devices. We use biofeedback, but biofeedback is not a proper way to measure the strength. They just give the activation, and most of the time when you strain rather than contract, when you strain, you see an activation at the biofeedback. So the proper way to see the function is the ultrasonography, pelvic floor ultrasonography. You use the linear probe and you use the pelvic floor transperineal from the perineus, you can observe the function. If it is squeezing and lifting the bladder. So you can also search for the coordination. While meaning coordination, maybe you can try for this. You can sit straight on your ischial tuberous, and you can just slightly open your legs, and your feet should be in contact with the floor. The upper body and lower body and glutes are relaxed. While feeling the tuberosities, in between these tubers, there's the pelvic floor muscles. And from the pubis to the coccyx, there's the pelvic floor muscles. So the perineum contacting on the chair is the muscles that you need to contract. So first of all, we give some, how can I say, to the patients, we just show where the pelvic floor muscles is. We need to do this, okay? We need to make some awareness of those group of muscles. So, and then, as I told you that there's 3 compartments at the posterior, medial part, and anterior part. You need to be sure that the person may able to contract all these 3 parts. So you may ask them, like they have a gases, so they need to hold it. So squeeze the anal sphincter at the posterior side. And if the patient is female, just progress the contraction to the medial part and progress it to the anterior part, to the pubis, squeeze. And now just lift it to your heart. Now, while releasing, this must be the same. First the anterior region, the medial compartment, and the posterior, and relax. Can you feel it? That you can contract and easily relax. So if there's a problem of the awareness, you may ask patient to put their hands to the perineum at the anterior and posterior side. And you may ask them to feel the contraction with their hands, okay? Or you may, as I told you, that you may put your hand just medial to the ischial tuberosity, okay? Consider that this is the ischial tuberosity. I will show it with the pelvis also. Just 2 of your fingers, or just your first finger, palpate it. When you palpate from the medial to the tuberosity, you may ask the patient to cough if you feel something just pushing your finger, that you are in the correct place. And you may ask them to squeeze and lift. And you may check it externally with your finger also. You don't have to do it like pelvic floor therapists do with their internal digital palpation testing. So you may try it and feel the sensations. And as much as you do this, you will be able to defer it. But when you do it with the patient, I'm sure that mostly you will feel like a strain to your finger. So this straining activity is very common among people, especially who has constipation. Or there may be some coordination problems. One can just squeeze the anal sphincter, but cannot squeeze the anterior compartment. When they squeeze the anterior compartment, they cannot squeeze the posterior compartment. So you may hear about leakage when they have gas in the bowel. They say that when they have this bowel function, they have the leakage. So, and also coordination with the diaphragm. Consider the diaphragm like it is function when it is dome gets down, the pelvic floor relax. When it is dome gets high, when you exhalate, the pelvic floor gets contracted. So patient may lose this coordination with the diaphragm also. You may teach this coordination, and this will be a proper way to teach them to control their breathing while contracting the pelvic floor muscles. Because you need to relax the pelvic floor while inhaling, and you may be able to contract the pelvic floor easily while exhaling. So you may teach this to the patient and work this coordination exercises. Another maneuver, there's a evidence-based technique, the nug maneuver, we call it. As I told you that a patient may have leakage during coughing or sneezing or lifting a heavy object. And we talked that weight lifters or CrossFit sporters has a risk factor of leakage. So you may teach them this nug maneuver. So whenever their intra-abdominal pressure will increase, you can teach them to contract pelvic floor muscles and then lift. You can teach them to contract pelvic floor muscle and then cough and then sneeze. So because they lose this, it is, we learn it, and involuntarily we do it in our daily activities. But when you lose some muscle activity or fascial connections, you use this learning of the muscles also. So you need to teach them again. You need to teach them how to use. So most of the evidence shows that when you activate the core muscles, pelvic floor muscles are activated also. But in my clinical practices, if you lose this fascial connection, if there's a muscular weakness, so we see that in patients, they lose the correct activity of pelvic floor muscles. So you need to teach it again.
Great. Thank you, Ayca, very, very much.
You're welcome.
It's so intriguing actually to go into this one, and I have the feeling from we just started. It's something we reached something which is not so much known in at least in our curriculum. I don't know if it's so much. Do you teach it normally in undergraduate courses?
We have elective courses on women's health. I give it in our university, Yeditepe University, and also give it in a different university. But those are elective courses.
Oh, this is really great. No.
Thank you very much. I hope you enjoy it. It's a very different subject.
Oh, I definitely think that we enjoyed it also when seeing, because this is the topics, and I really would like to ask you back to continue to have a different level. So we see now we really planned way too little time to go into it, and so I feel a little bit sorry that we have to stop because we have to move to a different session also again. But I really, would it be possible that we contact you again and that we gather some questions and that we make a next session?
Sure.
Yeah,
I will be glad.
Oh, that would be, oh, wonderful. Then for now, a huge applause for Ayca from all of us, and thank you very much.
Thank you very much for your invitation, and I'm so sorry that I couldn't manage the time and do these exercises with Deniz and Aslı. So it's a very huge topic, and I try to summarize that.
No, but we can't come back with you on this one, and definitely. So thank